From the JAMA Network, this is JAMA Ophthalmology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Ophthalmology.
Hello and welcome to our listeners around the world. You're listening to JAMA Ophthalmology Author Interviews. Thanks for joining us. I'm Neil Bressler, Editor-in-Chief of JAMA Ophthalmology, and today we're going to look at a post-hoc exploratory analysis of data from a multi-center randomized clinical trial from the United Kingdom, which was on patients with open-angle glaucoma or ocular hypertension who participated in the LiGHT trial. And they were initially randomly assigned to selective laser trabeculoplasty, abbreviated SLT, or primary hypotensive eye drops. And joining me to discuss this post-hoc analysis are two world experts in the management of glaucoma. First, Dr. Harry Quigley, a professor of ophthalmology from the Johns Hopkins University School of Medicine, who wrote a commentary on this post-hoc analysis titled Shedding Light on Selective Laser Trabeculoplasty. Harry, thank you so much for joining us.
Thanks, Neil.
And also joining us is one of the deputy editors for JAMA Ophthalmology, who oversees many of our glaucoma submissions and gives great insight, Dr. Michael Kass. Dr. Kass is a professor of ophthalmology at the Washington University School of Medicine. Michael, thank you also for joining us.
Thank you for asking me, Neil.
Harry, maybe I can start and then I'll have Michael chime in. Could you give us just a brief overview on what the LiGHT study was and what were the primary outcome results?
This was an important study in which people who had not been previously treated for open-angle glaucoma were randomly assigned either to get SLT, laser angle treatment, once or twice, or they were randomly assigned to eye drops. The first endpoint of the study was some years ago. It was 3 years in. Both groups did well. There was some minimal difference in what the visual field test showed. The patients were all happy with their quality of life for the study. And the investigators said, well, what would happen if we took the people who were using drops for the first 3 years and offered them laser treatment now? Would it still work? And would they actually enjoy doing that? So the editorial was about this post-hoc follow-up on the initial 3-year group, having now been given a chance to get SLT later.
So the people who were randomly assigned to drops at the end of these 3 years, was it pre-specified to then give them SLT, or was that something that came after the trial results were known?
The trial results were known, and then those on drops were offered SLT.
This was not a pre-specified hypothesis, and it was not a randomization either.
So what did they find, Harry, when they switched them over?
Well, the important thing that we pointed out in the editorial is that 2/3 of them didn't want to have the SLT. They kept doing drops. They felt they were perfectly happy with their drops. And as I pointed out in the editorial, this is noteworthy because these are people who agreed to be randomized originally to laser or drops. So it wasn't that they were against the idea of laser. And second, it's amazing that they had been told the laser was quite successful. And yet 2/3 of them said, no, thanks, I don't want a procedure. And I think it speaks to the fact that patients feel that procedures are inherently more risky than taking an eye drop every day.
And I presume that 2/3 were probably feeling like they were doing pretty well.
Well, they felt they were doing well enough without changing things. They also perhaps felt, I can always get the laser later if the drops stop working. Why burn my choice now?
So, Michael, do you find that people in previous glaucoma trials, given one set of treatments, are interested in switching to a different type of treatment?
Usually not, because when you come to a certain period of time, whether it's 3 years or 5 years, you have the survivors, the people who liked what they were doing, the people who didn't either switched or dropped out of the study. So you're taking a group of people that's generally doing well, not always, but generally doing well and generally happy. And people don't tend to make changes given those circumstances.
So, Harry, how did those people do, that 1/3 that were on drops, and then they underwent laser trabeculoplasty?
Well, the study showed that the laser trabeculoplasty still worked. In other words, the typical lowering of eye pressure that occurred on the virgin patients occurred also in this 1/3 who said we'll switch from drops to laser. So that was an important finding, that it probably doesn't ruin your chance of having SLT if you've been treated with drops before. Bear in mind, this was a post-hoc analysis and not a randomization. So we really don't know that that's the case, but certainly this is evidence in favor of it's not too late to have an SLT later. However, the patients who had moderate or severe glaucoma field loss did terribly with SLT. And this has been suggested from other studies, but was pretty definitively shown here. So patients who were in this study were all mild glaucoma who did well with SLT. And in fact, some of them were actually ocular hypertensives. 20% of the people in this study had no field loss.
So, Harry, you pointed out in the editorial in here that people with moderate and advanced glaucoma did not do well with SLT. Would you consider SLT as a primary treatment for such patients? And if so, under what circumstances?
No, I would consider primary SLT as a treatment for any untreated glaucoma patient. But I think we need to tell them what the odds are that they are likely to be successfully pressure lowered, and what the odds are that they're not going to need eye drops. And that's one of the things we made a point of in the editorial. The authors listed how many eyes didn't need eye drops. The problem is that people have two eyes. And so if one of your eyes still needs eye drops, you're still going to the drugstore every month, and you're not off drops. So what we actually don't know from the analysis, I can take a guess, how many people actually were off drops in both eyes for 3 years or more with SLT? And the answer is not the majority.
And did that surprise either of you that people still needed to take drops afterwards? Did it surprise you that the SLT had some pressure lowering effect?
It didn't surprise me because SLT actually works. We wish it worked better. And after years of messing with all the possible variables, we still don't have any way of making it more potent than it actually is. And in fact, the pressure lowering from SLT in the group that used SLT versus drops was not as good. The drops were better, actually, by a full point across a large number of people. So from the point of view of the clinically measured pressure in the office, the eye drop group actually had a lower pressure. That didn't give them a better field outcome, but it didn't also give them a worse field outcome.
And Michael, do you find that people after SLT, many of them still need drops just in practice?
Yes. If you're talking about people who have moderate or severe disease, the answer is clearly yes. Remember, this is a very special group of patients in this study. These are people who are treatment naive, volunteers for a study, usually younger, healthier, as volunteers are. So they're a special group. And if you take people outside this group more likely to have moderate or severe disease, I think SLT may be helpful, but I think the need for drops does not surprise me.
So, Harry, what do you tell your patients now in terms of the opportunity that they may be able to go drop-free? That's got to be something that some of them come to you about when you're introducing this other procedure.
Well, I tell them there's a chance that's better than 50-50 that they're going to be off drops in both eyes. I think that's a fair estimate from the SLT data. But that doesn't sound spectacular to some patients who go, well, gee, that doesn't 50-50. Why don't I just try the drop and see how that does?
Understood. And Michael, what do you think are the next steps that are needed after getting this information? Are we done learning about SLT? Are there other important questions that could be asked with it?
Well, we're certainly not done with SLT. One of the questions that Harry raises in his commentary is how often can you repeat SLT? If this works for a patient for 5 years or 6 years, and then the effect wanes, you can repeat it, all right? Can you repeat it a third time or a fourth time? And I think we don't have that information. I think in this study, some people received 3 SLTs, but we're talking about a lifelong disease. And if you have somebody, let's say, who's 55 years old, will this give them 30 years of benefit? I think that's unknown.
Michael and I both have patients who've taken drops for 30 years, and Tachyphylaxis hasn't happened with latanoprost or timolol. So that's something that's significantly different.
And Harry, finally, the SLT trials that we heard about today and discussed used intraocular pressure as their outcome. Does that translate fairly well to, let's say, changes in the optic nerve on OCT, or does it translate well into visual field changes?
Well, actually, let me qualify what you just said, because the SLT trial used quality of life as one of its primary outcomes, in fact, as its chief primary outcome. And that's quite typical for studies done in the United Kingdom, less commonly, but still being done here as at least one of the outcome measures. But is lowering of eye pressure beneficial for the visual field? Sure. Mike Kass in the OAT study showed us that for early glaucoma. Whether or not you need to do it in every single person who's an ocular hypertensive is another story. But I think from the point of view of a medium-term study such as this, with 3 years followed by 3 years, visual field and OCT should be part of any outcome measure. And in this particular study, neither group, SLT or drops, generally did better with regard to the visual field findings.
Well, I thank both of you so much for your insights on this information. Harry, thank you again for sharing with us.
My pleasure. Thanks for having me.
Michael, thank you as well for giving us some insight on glaucoma, its management. We're very appreciative to both of you.
You're welcome.
I'm Neil Bressler, and I've been speaking with Dr. Harry Quigley and Dr. Michael Kass about a post-hoc analysis evaluating selective laser trabeculoplasty, or SLT, among patients with open-angle glaucoma or ocular hypertension who enrolled in the LiGHT randomized clinical trial in the United Kingdom. You can find a link to the article and the invited commentary by Dr. Quigley accompanying the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks, everybody, for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.